Identifying patients at risk for sudden asphyxic asthma. Several risk factors are associated with sudden asphyxic asthma, including history of near to sudden asphyxic asthma requiring intubation and mechanical ventilation, hospitalization or emergency care in the past year, history of psychiatric disease or psychosocial problems, poor adherence to asthma medications, food allergies in patients with asthma, higher burden of underlying comorbidities in elderly patients with asthma. Patient history and clinical presentations are important factors which help in identifying patients at risk of sudden asphyxic asthma. The respiratory arrest-related factors include patients with a history of respiratory failure, sudden episodes of severe bronchospasm, frequent episodes occurring early in the morning, unexpected, rapidly progressive dyspnea, which may lead to respiratory arrest within a short period of time. Some aspects to consider during physical examination include high incidence of silent chest on auscultation in sudden asphyxic asthma, persistent tachycardia and tachypnea, absence of secretions suctioned from the airway in most patients requiring mechanical ventilation, higher rates of altered consciousness in the emergency department. Certain psychosocial factors and personality traits are strongly associated with sudden asphyxic asthma. Some have been mentioned here. Patients at a high risk of sudden asphyxic asthma may not be able to appreciate the degree of airway obstruction they are experiencing. Studies have shown that patients with highest changes or obstruction in airflow had the least perception of their airway narrowing. They have determined an inverse correlation between spirometric measurements and perceived dyspnea in these patients. Some medication-related factors which may be associated with increased risk of sudden asphyxic asthma are overuse of inhaled beta antagonists increases risk of hospitalization, poor adherence to medications, under usage of preventive medication, increase in usage of quick relief medication each month, failed response to repeated asthma controller therapy. Although there is no single screening test or laboratory measures to predict the risk of sudden asphyxic asthma, some important findings to be considered are, if patients are hypokalemic despite presence of acidosis, anion gap metabolic acidosis due to lactate accumulation along with hypercaric respiratory acidosis, profound acidosis with pH ranging from 6.90 to 7.0 millimeters of mercury, and severe hypercarbia, partial pressure of carbon dioxide average of 112.8 millimeters of mercury. Spirometry and peak expiratory flow findings to be considered while assessing risk of sudden asphyxic asthma are listed here. Some significant patterns of response to therapy in high-risk individuals may include ineffectiveness of therapy during initial periods, which is followed by sudden fall in pulmonary resistance within minutes or hours after therapy. Sudden bronchospasm and severe increase in required inspiratory ventilator pressures are warning signs.